Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Al Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
We're excited to share part 2 of our discussion with Dr. Enid Martinez. She's a pediatric intensivist at Boston Children's Hospital, and her research interests include gastrointestinal dysfunction and enteral nutrition in pediatric critical illness.
Yes, we were so excited to spend this part 2 just asking all of the questions we had about when she personally will feed her patients. Let's get right to the content.
As we transition now, we kind of talked high-level nutrition at this point, like estimating energy requirements and talking about various patient populations that might have various different needs. So much of feeding is incredibly practical, and there's so many situations that we were tasked with at the bedside. And so we'd love to do perhaps get your hot takes or clinical pearls regarding common scenarios that we found. So it's commonly said on the first couple of days of ICU rounds for a patient, we want to start trophic feeds to get the gut moving. Tell us, how do we define trophic feeds, and does it actually help kids?
People define trophic feeds differently. I think the most general approach to defining it is anything that's less than 25% of your goal, and it's basically non-nutritive volume. So I think that defines there exactly. One of the problems with trophic feeds is that it is not really helping someone meet their caloric requirements. Some people talk about it as 10%, 5%, etc., but it's just low volume feeds. I think the vast majority of patients do not need trophic feeds, and you can certainly start at that low volume, but then advance. We do start at about 25% of a patient's goal and then advance based on tolerance. But there's nothing that says that someone has to sit at trophic feeds for a long period of time. There are a few patient populations that I do consider it. Patients who have struggled with a lot of enteral nutrition intolerance, patients who have not been fed for a very, very, very long time. This happens a lot with the stem cell population because they've gone through conditioning and then they went through mucositis and then they ended up in the unit and were septic. And so now we're talking on weeks of that GI tract not seeing anything. In those patients, I do think sometimes there's benefit in starting very slow and basically waking up the GI tract. And then last but not least, in those populations and other patient populations who seem to be primarily PN dependent, I do try to trickle in even a little bit to try to keep the GI tract remembering what its job is for when the patient is ready to transition to full feeds. But it is not routine practice. I think it's very specific to these cohorts.
What do you think about starting with Pedialyte or Enfolite in these special populations?
Not needed. I do not, and not even half feeds, etc. Every so often we'll do it if we are stuck on understanding if someone's intolerance is due to the osmolar load or actual motility, but I never start like that. And at least all the dietitians I've worked with dislike immensely when we say, let's do Pedialyte, because the GI tract should not need to go through getting basically water before getting formula.
Enough said. Well, all right. We need to know what vasoactives you're feeding on.
It's a little bit patient specific, right? I'll say what the general sense of where people feel comfortable in the nutrition world is. And that is once someone is no longer being resuscitated. So definitely we would not feed someone who is still receiving boluses and escalating on pressors. Those patients, we would not feed their GI tract. But if they're past the resuscitation phase and they're weaning on their pressors, then we would, and this is the big nutrition world, we would explore feeding. I know that beyond there, it becomes very clinician specific. I personally end up feeding patients if they're definitely on that downslope of things and they're coming off pressors and they're maybe on just one pressor and it's at most a medium dose. And so I feel confident that they're moving in the right direction, and I would watch closely as I feed them. There are a fair number of purely observational studies. Nobody's going to go out and randomize this, of course. But at the end of the day, the vast majority of those studies have actually shown that our fear of feeding while on vasoactive agents is maybe greater than it needs to be. But I get it. So I myself tend to be on low to medium dose of any one pressor to feel comfortable to feed. But I don't feel like I need to be off pressors altogether.
Would that be like a convalescing septic patient maybe on 0.08 of epi, 0.1 of epi, 0.03 of epi? What do you think?
So definitely convalescing, like you said, and one agent, if it were epi, definitely not more than 0.1, preferably less than 0.1.
Got it. Okay, that's good. Last week I told my residents I'll feed up to 0.07. I was wondering, just wondering what you thought about that.
Yeah, you have to draw a line in the sand somewhere, right?
Yeah.
Yeah, and you have to watch the patient closely. And it's not just because they're on the vasopressor necessarily. It's the fact that they're getting over having been very sick. We're talking about the patient who usually ended up on multiple pressors, right, at some point and got liters of fluid. And so I think it's not just about the fact that they're still on one pressor, but it's rather where are they on their full recovery? Where are they on the fact that this GI tract probably completely shut down because the body was like, I'm not going to work on digesting anything right now, right? And so you do have to kind of keep that in mind. Is this a patient whose belly still seems distended? Are they, for whatever reason, usually they're still intubated, but if they're not, are they gaggy? So use other parameters too to determine whether they're truly ready.
Sure. And all the same caveats of like premature infants or those with cyanotic congenital heart disease. It's a bit of a different situation there.
No big sig lesions. I guess my other question, and it sounds like in these patients, they're convalescing, the vasoactives are weaning, but still definitely on. It sounds like you are not, let's now do 2 days of trophic feeds while we wait for this patient to completely recover. It sounds like if you're going to feed them, you'll actually feed them.
I will, but we will keep an eye on how they're tolerating it. And I need to say the caveat. Here's the disclosure of this is what Enid Martinez would do. It doesn't mean that everybody at Boston Children's does this because there's a little bit of, like I said, it's not just about where the medication is, but about the whole patient. So it's very patient specific. It's very provider specific. And I totally respect that because it's a very gray zone in critical illness. And nobody wants to be the one who fed the patient who then had some sort of ischemic bowel. But yeah, so what do I watch out for? I'm watching out for any signs of intolerance, which could mean worse abdominal distension, right? Evolving abdominal distension. If they're able to somehow let us know abdominal discomfort, diarrhea, vomiting, and the ever so controversial gastric residual volume. We still use it. We recognize that it is limiting. We recognize that there's definitely strong adult data to suggest that it is not the best marker. To be clear, the adults looked at gastric residual volume in the context of ventilator-associated pneumonia. So it's a little bit different about thinking about gastric residual volume and GI tract function and so forth. And there is a randomized controlled trial on the way in the UK, and we're very interested in what the results are. But the way that we use it is that we use it in conjunction with those other symptoms. So we don't use it as a single sign to say this patient can't feed. But if they have that and abdominal distension, that and vomiting, that, then we don't disregard the gastric residual volume.
So tell me this. Let me paint you a clinical picture. Say this child is convalesced from the worst of their critical illness. They're all vasoactives, but they're having feeding intolerance. You're maybe perhaps noticing some vomiting. You're noticing this increased gastric residual volume on your tube feeds. Say you've excluded anatomic causes of issues with feeding. Do you have a particular style of how you would either prescribe or not prescribe prokinetic agents?
We tend to go to post-pyloric for the most part. The evidence on the prokinetic agents it's actually kind of lacking in the pediatric world, and it's not terribly strong in the adult world. You can certainly consider them and give them a try, knowing that they also tend to be the kind of agent that you might not want to be on for a long time due to their interaction with other medications or antibiotic resistance if it's erythromycin, et cetera, these bigger picture concerns. But we tend to prefer trialing post-pyloric, which does tend to then work for our patients a little bit more than the prokinetic agents. Having said that, it is very common strategy in that algorithm of addressing enteral nutrition intolerance. And if it's one of the tools you have at the bedside to use, you should definitely consider it.
Yeah. It seems like your general practice would be to trial gastric feeds if all possible. And then one of your early steps in feeding intolerance would be to try post-pyloric. Is that fair?
That is fair, yeah. I think it has to do partially with the fact that we have an excellent group of nurses that are able to place the post-pyloric tubes at the bedside quite successfully. We have looked at our own practice and found that upwards of 80% of bedside placed post-pyloric tubes are successfully placed. And so I think it makes it very easy for us to say, well, then let's just go post-pyloric. But if I was in a circumstance where that was not as easily placed and we were having to invoke a trip to interventional radiology or fluoroscopy and it was going to take 2 days to do that, I would totally try out a prokinetic.
Nice. When you two are discussing this question, are you thinking about these are maybe previously healthy, intubated for critical illness children, or are you thinking about sort of the broader complex care population?
If you're asking me, it seems like this comes up quite a bit in our kids with chronic medical complexity. Usually the kids with previously healthy who don't have like real residual organ failure, usually they snap back and feed well.
Yeah, I agree with what Zach has mentioned, which is that it is the patient population that's complex, either because they're chronic or because they're very complex. Like the stem cell population, we bump into a lot of enteral nutrition intolerance. As mentioned, someone who already had kind of gastrointestinal issues, I think we bump into more issues there. I think our practice is true for both the patient who was previously healthy who doesn't seem to bounce back and the patient who is more complex. We would still attempt post-pyloric, but I agree that this tends to be more so in the side of the chronically ill patient, which, by the way, if they already have a G tube, you can also very easily convert that to a GJ tube. So I think that's another reason why we very easily sometimes move down that route as opposed to, again, invoking prokinetic agents.
Oh, yeah. I think that this is a good reminder in my own clinical practice to consider post-pyloric feeds more often. The one thing that I always consider a joke that always works is methyl naltrexone, right? If the patient's been on an opioid infusion for a while.
Yeah, constipation is not spoken enough about in the ICU, and for sure it can lead to someone having intolerance and at a minimum discomfort. And you're right, sometimes we add softening agents such as, or bulking agents such as Miralax and fiber. And then we add the kind of more motility agents for the colon like Senna and bisacodyl, and nothing's happening. And the reality is that if you're not stooling because of those mu receptors, right, being stimulated by opioids, then methyl naltrexone is going to be key. But, for some patients, that's not the problem. And so you'll know, right? Methyl naltrexone either works or doesn't work. That's the good thing about it. There's no like, oh, I need to titrate your dose. It's like, okay, that wasn't your problem. I'm going to go figure something else out. One thing I want to say quickly about why I also tend to go down the post-pyloric route is that the research, both from the adult world and what we have been doing in the pediatric world and even some animal work that I've done, has shown that when you are systemically inflamed, your stomach is much more affected than your small bowel. And so you get much more dysmotility of the stomach than the small bowel. Hence the fact that many patients that don't do well with NG feeds can do well with post-pyloric feeds. And so you can try the promotility agents, particularly for the stomach, like erythromycin and metoclopramide. But if the stomach is severely dysregulated because of critical illness, it might just not even respond adequately. And that's why kind of just bypassing the stomach is better. And that's a whole different conversation from colonic slowing, from dehydrating our patients with diuretics, from being NPO for a long time, dysbiosis, medications, as you mentioned, et cetera.
We might not keep this, but this is a bit of a side, something that I've observed that may or may not be correct. I just notice in kids who have chronic medical complexity, who have maybe chronic organ dysfunction in the ICU, intolerance of feeds being a symptom of like poor organ support otherwise. So maybe the child that we're trying to limp by on non-invasive, maybe without a trach, or maybe the child who has issues with coming off habituation medications. I feel like I see maybe the intolerance of feeds just being another harbinger of like another symptom of some other organ dysfunction. Do you see that way or no?
We do see that. I know I keep mentioning the stem cell population, but I think this is one population we see it a lot. We get them through that hyperacute episode of sepsis, respiratory failure. And now, we think they're on the other side and we're struggling to feed them. And I think it's just reflective of the fact that they are maybe not in that hyperacute phase of their illness, but their body is still feeling quite systemically inflamed. And I think the GI tract gets hit. The other thing is sometimes the gastrointestinal tract, after someone's been on multiple antibiotics, have had periods of hypoperfusion, etc., have been severely fluid overloaded, which that goes into the actual intestines and the abdomen. When you think about all those hits on the gastrointestinal tract and the fact that now you have dysbiosis, your enteroendocrine axis is off, your neuro axis is off, I think there's a lot of components that need to kind of slowly recover for the gastrointestinal tract to go back to normal function. And those can take a long time, when you think about changing someone's microbiome so that their signaling can return to what it was before, et cetera. So I agree with you, Zach. I think sometimes the GI tract ends up reflecting both how sick someone was and how not fully recovered they are, even if we're off pressors, even if we're no longer mechanically ventilated.
So we talked a lot about enteral nutrition because it's most important, right? But say in a general PICU population, for some reason or another, our child is having issues tolerating enteral nutrition. At what point do you seriously consider starting TPN?
So I can't talk about TPN without mentioning the randomized control trial, because I think it's one of the RCTs that has been performed in pediatric critical illness nutrition. As we all may know, this 5S study, they randomized to either starting TPN on day 1 of admission with basically near complete PN prescription. It wasn't like D10. They actually went to like D30, or TPN on day 8. And in the interim, patients could get enterally fed if they had any kind of tolerance. And so that was up to each unit. And what they found was that, actually very similar to the adult studies, that those patients who received TPN on day 8 ended up getting discharged earlier from the ICU, had less days on the ventilator, and less use of CRT. So I think that has been now applied differently from unit to unit. Some people practice that protocol where you don't get PN unless it's been a full week of basically not being able to get either adequate nutrition or no nutrition. But there are some of us who think that there's some patient populations that you would and should at least start thinking and talking about TPN a little bit earlier. What I think we all agree on is that you do not start TPN day 1. Some exceptions are patients who are PN dependent. So if you were PN dependent, that's how you've been getting nutrition, you're kind of in a different bucket. So then you're in this middle phase. Some things that might make us consider TPN earlier include a patient's nutritional status. So if they're very malnourished, it's a little bit hard to sit and not be able to feed them for a full week and then start TPN. So we're talking about the patient who's not getting any enteral nutrition, right? Because if they're getting some EN, then they're getting at least some nutrition. But if they're both very malnourished and not being able to get any enteral nutrition for whatever reason, it is a little bit hard to sit down and not feed them at all for a full week. That is true also of neonates. It's a little bit hard to not feed them for a full week. And so what ends up happening is that we start discussing starting TPN on those patients often anywhere from like day 3 to day 7, depending on where they're at in that window. We'll start discussing it and often start it earlier.
So let's say a patient has real feed intolerance. They need maybe a few days a week of TPN, and then we start going up on that enteral nutrition. Is there a right way to sort of switch it over and wean off of the TPN?
For most patients, if their GI tract recovered and now they are tolerating their full nutrition, for most patients, the answer is you don't write for more PN because they prove to be doing well. There are a few patients that you might want to think twice about doing that. So maybe someone who's having to go to the operating room a lot, or maybe they finally hit their full nutrition, but you know you're way behind because they struggled for the first week or two. And now they're having to go to the operating room. You have reasons to stop their enteral nutrition. Or maybe you're worried that they're close enough to goal. They're at that 60%, but not quite 100%. So there are a few patients for which you might overlap the TPN with the EN for a few days and then pull back on the TPN. But for the vast majority of patients, basically, as you advance that EN, the PN would come down. And then when they reach goal, I wouldn't write for more parenteral nutrition.
Wonderful. Very pragmatic. Yeah, I will say our conversation today has been great. We've had high-level discussion about estimating energy expenditure and leaning into various specific clinical situations where sometimes evidence doesn't speak directly to that, and there's a bit of clinical style, and we appreciate you navigating that with us.
Well, Enid Martinez, thank you so much for joining us today. It was such a treat to be able to ask all of our nutrition questions to an expert.
Well, thank you both again for the invitation, and it was awesome to talk nutrition with all of you. And I hope that this triggers more conversations about what to do at the bedside, particularly for some of those questions that we're not quite sure how to approach yet.